Welcome, everybody. I'm Dr. Prof Anwar from Windsor Health Centre.
I'm Dr. Anwar Ahmed, Windsor Health Centre, GP and trainer.
I'm a trainer too. And the subject we're going to be talking about today is very pertinent to trainers. So let's introduce Dr. Anwar Khan, who is
a professor.
A professor. So he's an eminent, very eminent.
And he hails from round these parts. Very important. He's from the Northwest originally, where all great people come from.
Thank you for the wonderful introduction. But you're absolutely right. I went to the grammar school in Stockport. Very fond memories of the Northwest. But as I say, I've been in London for the last 4-5 decades now. So, oh my God, it gives away my age. Okay.
So we're going to talk about Clinitalk today. And so can you give us a brief overview of what it is?
Yes, but do you want me to tell you a little about the journey, how I got to it? So I think Nick Box and Pete Salmon were the ones who founded it. I came across it when I was teaching on one of the RCGP SCA courses, because I've been an examiner for nearly 3 decades. And what really struck home to me was, at the moment, the training nowadays is analog. There's very poor data about performance of trainees and their learning trajectory. We all talk of Bloom's taxonomy, but do we actually, I mean, you've got it on the portfolio, but do we actually turn the screw when we're talking about case-based discussions with our trainees or whatever? We do think today's training is inequitable, and I think some of that lends itself to the real shall we say, holy grail of differential attainment. And even though we talk at the exam in the concept of differential, I don't think it is. I think it's a journey. So for me, it's that. The other thing is today's training, if you have, I'm very lucky. I'm still a jobbing trainer. I've got 2 at the moment. But if you gave me 6 trainees, I'd find it difficult. It's not scalable. And actually, most of us, and I hope you agree, we do a lot of that through the goodness of our hearts. It does cost us money to do it. Yes, we get inverted commas help with some of the clinical bits, but for the amount of time we would spend, if you're conscientious, we do that. And when I speak to trainees, they say, I'm on track, and they want affirmation. They don't get feedback for most of their consultations. I was actually shocked how many of the trainees on different courses, how few of them actually get regular consultations. With my registrars, we say from day one, we're going to have at least 2, if not 4 consultation pots from day one. As we lead up to the SCA, we do it every week, and we'll have 2 or 3. But we don't do that. And I think people forget that actually the way we consult is our basic tool. My son has gone to the dark side. He's an orthopod. His basic tool is a scalpel. My basic tool is my tongue. And I tell you, it's sharper than his scalpel. But how many of us practice using our consultation skills? Most of us are good communicators. So it's all implicit. But I think looking at COTS makes the implicit explicit and shows where strengths and weaknesses are. And I don't think enough of that is done in training at all. So I think, and this is why I think the future is really bright. We used to say future's orange, didn't we? This is a mobile network. Because actually there is a lot of data. If you collect consultations on a regular basis, society is now very much on demand, isn't it? And we want things instantly. Well, why can't we? So Clinitalk looks at that. We want access to everybody, and hence equity. We want to be building a data and an evidence space, and as you 2 are very into AI, much more than I am, that gradually through machine learning, you using the evidence to make things better. it's scalable. It's, there's no limits. You can have as many consultations you like, and it is cost efficient. Once you do it. So ClinTalk is really about improving the training experience, helping to tackle this thorny problem of differential attainment, but actually being scalable, transformative, and inclusive. That's basically what ClinTalk's about. And I think, and again, you probably need to check with Pete, but I think it was last year that we got assured for use in live consultations because of the end-to-end encryption. But look, I'm not the techie guy. I'm just the educationalist.
Okay.
And it's interesting, we all talk of consultation models. Well, there is a specific consultation model the exam promotes, just like Roger Neighborhood, the RTGP was based on the video exam, as you know, from Peter Tate, etc. So there is a style of consulting that we do expect candidates to do. Now, you all know life is much richer than that. We often move into Urdu or whatever other bits of things or diagrams and whatever it is. But in the SCA, there is a certain standardized thing. And I think that's what we're trying to do. We're trying to get people using ClinTalk and for a while get used to that style. And by the way, it serves my function quite a lot, actually, and I'm still a jobbing thing. So there's a very simple, intuitive interface. It's on the mobile. It's also on the computer. And it's the mobile bit that I particularly find helpful. And that will sort of give an overview of number of consultations, average consultation time length. And then we've got some parameters about time spent consulting, time spent listening, time spent sharing, and we benchmark some of those times, and we put red and green to make it look look easy to do. It's very easy to record. You just on your mobile, just press the record button. And what we've done, we've split the consultation into 3 parts. One is the story part, the beginning bit, which is really, as you know, where we like doctors to keep their mouth shut. We want the patient to give their speech. People called it the golden 2 minutes or whatever golden thing you do. I think it is about listening to the patient. The tool does identify in 2 different colors who's speaking when, the doctor and the patient, and we can work out who spoke most in the first 2 minutes, who spoke most in the middle third, who spoke most in the final third. Oh, the 3 bits. See, I do go off topic, so please stop me if I'm wrong.
That's right.
The 3 bits are 1, story, 2, questioning, 3, management.
Right.
What we've also done, and this is where it comes back, again, I've got different roles, but I'm actually the lead for the induction refresher exam, which is for overseas GPs, all GPs from this country coming back to this country. And Peter Burrows and I invented it in 2003, and then it became nationwide in 2006, and now we're running it. And one of the things I've been doing since then is working with a linguist, and I'm very keen to see the words they use, where, etc. And one of the things I say to my registrars, I want you to develop a phrase toolbox. Phrases that work, phrases that don't work. Don't copy Anwar. Make your own. Why do I say that? Now, both of you, you're wearing scrubs. Can you feel the weight of your scrubs?
Yep.
No.
Because you're used to it. Now, Amar, if I made you wear a sari, it would keep falling off, wouldn't it?
Absolutely, certainly. Absolutely. And exposing
that might be that might not be the only problem, but
yeah. But the point about it is you wear the clothes that you like to wear. Hence you use the phrases that you are comfortable with, not what your trainer told you or what the examiner Anwar said. Because actually primary care is a lot richer than that. So anyway, that's my clothes analogy gone. So what we do is give you real-time feedback, and that will be things like top tips. We'll give you feedback. And we've only done this because of the SCA in data gathering, in clinical management, and in relating to others. Okay. And we'll give you scores on timing, time spent listening, time spent sharing, rapport, etc. And the thing I really love about it is it gives a report on topics covered.
Right.
Why?
So,
it may be, Amar, you answering enough gynae patients because they all go to Faria. Yeah. And then you'd see, oh, I've got no gynae patients here. Oh, I've got no genetics patients here. I better go and look out for some. So it does do curriculum coverage. So it does help you to do that. It does look at the average conversational balance and that trend. So what we're saying is, you know what? You're just having too much of a doctor input. Decrease it or increase the patient input or lower that patient input. You know, why is the patient talking at the end with summarizing it? You know, so think about how you plan that. And what we'll have is a consultation history. So there might be things like sore throat, postmenopausal bleeding, trigeminal, and they'll be written on with the main topic which the trainee enters and the consultation time. Also consent, by the way. So there's consent inbuilt into that. In a summary, that's what Clinitalk does. Now, what we're trying to do is, through that conscript, really just summarize the history and the management. Now, there's other tools that do the same. And then you can copy and paste that into your notes. Or delete bits, but it does that. Then we have feedback generated through AI, and this is a bit that we're developing to be better and better, about ideas, about concerns, about expectations, about the management plan, red flags, clear language, identification of patient cues, being curious.
So
kindness. This is part of the new GMP now, isn't it? Kindness. And then what we're doing, and by the way, over the years, I found if you give more than 3 feedback, they never remember it. So preferably 1, maximum 3. So we might say, explore patient ideas more thoroughly, acknowledge and validate their concerns, and offer more immediate pain relief. Example. And don't ever give more than 3. And that's what we need to.
So we're talking about a co-pilot for a registrar to use every day in every consultation, and it gives you feedback and helps you develop every time.
Absolutely. And that's what we're trying to get. Sorry. So the way, but Amar, that's a beautiful summary. So the way I would say it, and trainers are going, you're going to try and replace me. It's a bit like when you order a full blood count, you get the hemoglobin, the MCV, etc. We'll give you the normal ranges based on our experience to date. But what I'm hoping, that will be the springboard for even new trainers who are inexperienced about consultation. I mean, I'm an anorak when it comes to consultation, but some people may not be as confident. And having this common springboard allows trainers to augment it and make it even better. And that way, we have a common basis for people to improve and maybe help that journey. Because remember, differential attainment is a kick in the teeth. Most doctors, clever people, the top 2% of their population, they're not used to failing. And then you fail them at the end of your journey. Now, it's interesting. So one of the things I'm looking to do in East London is have a medical school that actually isn't there for the pass fail, which now is done by the MLA, but it's there to track the journey over the 4 years. You don't want people to fail at the end of year 4. You want to be turning the screw if you need to, or affirm if you need to, if they're doing well, so that journey is as smooth and seamless. But at the main point, you've got to have patient safety. And that is the bit, as an examiner, I find just helps me to work out pass and fail, because I don't like failing people. But you know what? If patient safety is at risk.
No, totally agree.
And this does this like straight away? Can they see it immediately after the consultation?
Yes, I think it's within a minute.
Brilliant.
So they have to write in what the consultation is about, and then it uses and again, please ask Pete or because he's our techie. It uses CKS guidelines to bring up some top tips. So if it's infertility, it'll bring you some top tips about which test you could have done or whatever.
No, that's brilliant. That's great. Because like even if we do a recorded consultation, we'll do 1 a week or 2 a week.
And we'll have to wait.
And you have to wait and then see if it's had an impact. So this is like almost real time.
Why registrars that maybe come from other practices, that one of the key things that they're saying is, look, I didn't get any feedback. I don't know if I'm doing right or wrong.
Yes.
And this would be an amazing tool for them. So I will ask Nick about all the technical side, because there's quite a lot of people are very aware of potential security concerns, and I'm sure it will meet all of those things. Once we've got all of that assurity, I think I'm going to try to get it into our practice for our registrar.
Yeah, right. Yeah. I was just looked up the course. So the year's Clinitalk with the year's subscription, a day course. So it's $295, which I think most registrars could probably, if the TPD approves it.
Yeah. And then that gives you a year's worth of personalized daily per patient feedback. I mean,
and the trainer can see it as well. So that's good, isn't it? So your tutorial.
That's a very good point. So the trainee pays, not the trainer.
Yeah.
Because the payment is actually for the transcription and whatever gubbins goes on behind the scenes. But the trainer has free access. And the other thing is that if someone has more than one trainee, if they're both trainees or how many trainees they have give permission, he can look at all of them. So if you're a trainer, if you're a TPD, for example, and they all give you permission, which I don't know if they would, or it's only if you've got 2 trainees like I have, I can look at both of them and see the trends and be able to give them feedback.
And do you think someday it will actually integrate with the portfolio?
Well, that's a very interesting thing. I mean, from my perspective, I mean, it's been an eye opener for me, AI. I've luckily got some younger colleagues, very much younger colleagues, who are doing MBAs with AI and in healthcare, etc. And I'm actually with the new medical school, I'm planning to have a lot more use of AI and be it virtual reality, etc. I can see a future where you've got role players done by avatars.
Wow. Yeah.
I really do.
Standardize the role players in exams.
Well, I think so. And I was speaking to somebody yesterday, because I'm a member of the council, that we've got in the States avatars that will respond to different consulting styles.
Yeah. I'm
already talking to somebody at Bristol about using avatars as role players for medical students. And I think a lot of the healthcare professionals, like nurses, etc., could do with that. So I can see that coming first. Whether or not you'd have avatars examining, it's an interesting debate, and I don't know. And you might say, well, turkeys don't vote for Christmas, and I'm one of the turkeys, so I don't know. What we did know is, in the old days, there were assessments from Leicester, actually, that talked about role players playing the role and grading the students. It was the Leicester simulated surgery package and things. And one of the big criticisms I think candidates said was, how can a role player play the role and examine? And actually, I wanted the GP making the judgment. So I think there was this aspect of you want a jobbing GP. And I must say that one of the things I would say about, I mean, obviously I would say it one time, is that all examiners are jobbing GPs. I mean, it's only recently I've been given the honor of Prof, by the way, but I've been a simple East End GP for all my life, and I'm proud of it. And I think that's one of the great things of examiners is we would say, wow, that was a difficult case, and actually they mark accordingly in that or whatever. So they know what is realistic within the 12 minutes. Now, you two, because you're much more into AI than I am, you can say, well, we can program the AI to do that. And maybe that's the way to do it. But
yeah,
I'm not going to get involved in that debate.
I find it very difficult as a trainer. I've been a trainer now for almost 18, 19 years, and I've seen the thing evolve. I find it very difficult to keep all those criteria in my head and give a standardized mark. And I would say one of the use cases out there, which is just staring at us in the face, is just e-portfolio grading and marking and comments. I mean, it doesn't need hours and hours of our time to do that. And if it can analyze the consultation and the audio, then certainly it can analyze the text that registrars are putting in.
It can certainly do that. I think that's so. It's interesting, isn't it? So really, what we want is acceptability by the candidates, and maybe that would drive it. But you're absolutely right. Maybe the technology will be there, and I certainly know there is technology for the role players, so may well be. The thing I would caution trainees against, and I don't want to get caught up by excellent authors who've written wonderful books on SCA scenarios, but I do find SCA scenarios and CSA scenarios are often too comprehensive, and that I would think, oh my God, I can't finish that in 12 minutes. So, and I just worry that those things just raise the angst a little bit too much.
Totally agree.
And by the way, I hope any SCS authors, I don't get any bad letters from, but that's my personal view, because I do think trainees are frightened enough.
Yeah,
we don't want to frighten them more, and we do want to talk about. It's about patient safety. And one of the things I say to my own registrars, and I mean it right from the beginning, they don't believe me until they pass, by the way, is I say to them, you practice every day, you practice safe medicine, you practice evidence-based medicine, and as a side effect, you will pass the exam. And I think that, and this is what Clinitalk does.
Yeah.
You're doing it, reflecting, and it's back to, and you all know this, Kolb's cycle, because it fits. So there's a lot of, as I would say, educational thing. It's aligned very well with Kolb's learning cycle, doesn't it? So if you remember, with that one, it's got the concrete experience, the reflection, and then it's got the abstract conceptualization, and then it's got the active experimentation. So what you're going to find is that, in essence, Clinitalk is Kolb in reality.
Well, I think we will certainly be pushing this in our area, certainly with our own registrars. I've got one in mind for it straight away. And that's I'm so glad that we discovered this really by accident on a WhatsApp group. I didn't realize it was already here when we were discussing it before. This is a perfect use case for this kind of stuff. So thank you for that, and it's been a real honor speaking to you. And hopefully we'll get some more programs out of this, because the whole training agenda, it's causing a lot of discussion amongst the younger doctors and the younger GPs. And, I think it's really important that we kind of air a lot of their concerns about the whole system and the whole system of assessment. So, I hope to see you again soon.
But Amar, can I just say one other bit, just to reinforce this, is we do need feedback from trainers and from trainees, because this is still on an improvement trail. AI is about improving. So what I don't want the people to say, and I'm sorry, but you have the last one in a minute, but I just want to re-emphasize that message. No tool is perfect. It's just a starter for 10. It's I think a very good starter for 10 that allows the trainers to really augment it. But most importantly, the icing on the cake is the trainee to reflect and really go round Kolb cycle. But thank you for your support, and thank you for your kind words.
Thank you for your time. So that brings this session to an end. So we'd just like to say thank you to the Prof for speaking to us and telling us all about Clinitalk, and hopefully we will see you again at our next.
And I'll put all the details, the pricing, and all the other stuff in the description of the video below. So please like and subscribe. Take care, guys. Bye.